So I was given this topic here, placenta and maternal stress, and the question gatekeeper or fortifier, and I will try to answer this. So I believe that the major question we have nowadays, and not only in medicine, but also in politics and so on, is what defines our long-term health? And how can we actually improve our long-term health? And just very roughly, we do have our gene pool, we do have modifiers we can probably tackle to improve health, like food and activity, but all the big programs, WHO programs, have actually failed really to have a big impact on health improvement. And that's where the concept of early life events and, let's say, perinatal programming becomes interesting. And I do not want to talk too much about programming. You already have seen this in a much better way. The only thing I would like to highlight here, that you really see the U-shaped curve, and I will show you this graph with respect to the placenta development later on. So just remember the U-shaped curve here. And David Barker, who actually made this concept to the public interesting, but actually this is a conceptual framework, and you probably know that a colleague here from Berlin, Professor Dörner, very early in 1976 already talked about some kind of perinatal programming, and this concept developed, and nowadays we have the Doherty Society, as you all know. So and two important things about programming is that you have different types of stress, and stress means nutritional stress, stress means changes in oxygen, and stress means also changes in hormones, and those different parameters affects fetal development and has some postnatal changes, as you all know. And the second important thing is that you have to have in mind that there are sensitive windows. So if you look in different outcomes and studies and so on, there are sensitive windows, and you might not see an effect if you have an adverse event if you put it not in the sensitive window. So there's a huge body of literature out which actually has proven really that prenatal stress causes perinatal programming, and we do have now quite good evidence that prenatal stress, meaning all different types of stress, is associated and results in a wide variety and range of changes in long-term health problems. To investigate perinatal programming, you have different models. So you can choose models where you look at nutrient modification. You can either feed in the models, like a rat model, you have a low protein model, you have a hypocaloric model, and a hyperfat model. Then you can have some older models used, an IUGR model. You can modify temperature and so on, and then you have a stress model, and stress in the stress situation, you can use glucocorticoids, and this is interesting for an obstetrician because we use glucocorticoids very often during our daily life. And we thank this guy here, Sir Graham Liggins, from the Liggins Institute in Auckland, New Zealand, who actually invented glucocorticoid treatment in humans. And he started, not in human, he started in sheep, where he could prove that antenatal glucocorticoid treatment reduced significantly the rates of RDS in newborn lambs, and at those days it was very easy and quick, so he started this experiment in 1969, and 4 years later he already conducted the first trial in humans, so it took very long to prove this concept. So nowadays we know that antenatal glucocorticoids, like betamethasone and dexamethasone, they are tremendously helpful in reducing morbidity and mortality in newborns. But we do also know that, especially if you give high doses or you give it in probably wrong windows, there are some side effects. And side effects are related to weight. So you see reduced birth weight as a surrogate marker, only a surrogate marker for fetal development. You see changes in neurological development, changes in HbA axis, hypertension, and so on. So I started to work in the sheep as well. This is our glucocorticoid sheep model, and I was very happy to collaborate with a couple of very clever people around the world. And we did the sheep experiments in Australia and Perth with John Newnham and Tim Moss, where we have really worked in the shed and exposed our sheep with glucocorticoids, and we had different protocols. So we wanted to really focus on sensitive windows. So we had glucocorticoid treatment early in gestation and also late in gestation. And the doses were similar to the human dose, so you can calculate it to the maternal weight and inject it intramuscular, so also have the same application of antenatal glucocorticoids treatment. And what we found, which is nice to reproduce in the sheep model, that if you treat a sheep with antenatal glucocorticoids, here this is the control weights, and this is the treatment group. We found after glucocorticoid treatment, and this was a repetitive model, there was a decrease in fetal weight. This model works for programming because we could show that if we treat pregnant sheep with antenatal glucocorticoids in the follow-up, we see neurological and also endocrinological changes. So in adulthood, those sheep developed an HbA hypoactivity due to adrenal insufficiency. So this model works to investigate programming. And I'm an obstetrician, I'm not a veterinarian. Coming from this data, we hypothesized that betamethasone, antenatal glucocorticoids, also result in a growth restriction or an impairment in fetal growth also in humans. So we conducted a case control study where we enrolled over 44,000 singletons, divided them up into males and females. You've already heard that it's important to look into the sex. And then we looked whether betamethasone in a dose-dependent manner would actually affect birth weight and fetal growth. And what we could show and repeat in this study, that antenatal glucocorticoid treatment in the time window we normally use nowadays, up to 34 weeks of gestation, we found a significant decrease in birth weight when they were born compared to the control ones. Here, these white bars. With respect to sex, we found differences. So there were much more obvious changes in females compared to males. So the effects were more obvious in females, and this fits somehow to the concept we heard from Torben Kieberoth before. So, and we hypothesized, and others do this as well, that females somehow have a constant glucocorticoid sensitivity, ensuring reproductive capacity, whereas males actually invest in fetal growth. The only thing is, if you have a second hit during pregnancy, then fetal growth is impaired in males as well. So the changes were not only in growth as a surrogate marker, we also saw changes in body length and head circumference. And 0.6 centimeters in head circumference might not be very much, but if you think that you can calculate brain volume, for example, from the decrease in head circumference, you see a decrease around 11%, and this is quite a lot. And there are others, like Davis and colleagues, who did a very elegant MRI study where they looked at glucocorticoid treatment at the follow-up of 6 to 10 years, and they did MRI scans from the brain, and they could actually demonstrate that those who had glucocorticoid treatment during pregnancy had changes in the thickness of the cortex. So glucocorticoid treatment also in humans has long-term effects. New in this study was that we could actually demonstrate changes already during fetal life, because we did ultrasound and we measured and we did follow-up measurements in those fetuses, and we could demonstrate this actually after the betamethasone treatment, when they kept pregnant, a decrease in fetal estimated weight, and there was a dose-dependent decrease. So as higher the dose was, so higher doses means more than 24 milligrams, so repetitive treatment, we saw a decrease in ultrasound fetal estimated weight Z-scores. At birth, there was also a dose effect. As higher the dose, the greater the reduction, but, and this is something we always strive to tell people, higher doses actually did not improve neonatal outcome, so it does not really make sense to treat patients with higher doses. We did not only do this in singletons, we also did it in twin pregnancies, so looked into our birth chart registers and analyzed those data, and also in twins we found this growth restriction. In twins who received betamethasone, and when they were born early preterm or late preterm, there was a decrease in fetal growth, and we adjusted this with a twin model, step 1 and 2 analysis, and so we could reproduce this in twins as well. And also we found a decrease in head circumference and body length, so there's a symmetrical decrease in growth after glucocorticoid treatment. With respect to follow-up, because this is what people ask, does this really have an effect in long term as well? And this is data we have not published yet. We just finished the first step of analysis at the couple of weeks ago. So we took from those twins, we were 600 twins initially enrolled. We were able to get data from 214 neonates with female pairs, male pairs, and mixed pairs. And we asked with 2 and with 6 years how they developed. And we took the, in Germany we have a follow-up Kinderhead, where we record the development of the child, and we took this data and analyzed this with respect to antenatal glucocorticoid treatment, and we could actually show that an increasing dose in those twin follow-ups increased the rates of infection and sepsis in the neonatal period. Males did worse, so with 2 and 6 years we found increased rates of speech disorders, less first 3 steps and more motor clumsiness, and higher doses in males actually may reduce the rates of pronunciation disorders and motor clumsiness at 6 years of age. And this is something, so we saw a difference between males and females, and probably we can in the future offer a more individualized, probably basically on the sex, treatment protocol. But this is data we have to go on and to analyze this further. So coming back to my the topics of the placenta, the question is how is this all happening, and how can actually glucocorticoid or stress affect fetal growth? And it has something probably to do with this beautiful organ, the placenta. You remember this U-shaped curve association, birth weight and risk. And interestingly, you have a similar association when you look at placenta weight as a ratio of birth weight and the risk for coronary heart disease. There's also this U-shaped curve. If you look into the literature and to see whether there are changes in the morphology of the placenta with respect to placenta weight, with respect to the size of the placenta. You find a huge body of references who actually found changes and association with later outcomes. So placenta, just from the epidemiological side, seems to have an impact on fetal growth development and also on programming. Barker defined some phenotypes of placenta, like weight, surface length, thickness, cord length, and associated those things to later life disease changes. And he also speculated some processes which might be involved in the placenta to induce those changes, like spiral artery invasion, like surface growth, like cord development, and so on. In our sheep model, we did not only found this decrease in birth weight, as I've shown you before, we also found a decrease in placenta weight. So placenta in our sheep model probably has something to do with fetal growth in regarding to sex. And not only betamethasone affects placental weight, all different kind of intrauterine exposures can actually influence placental weight and efficiency. Sheep placenta is somehow different. So we have a bicornate uterus. We have little placentomes, like separate placental units, 60 to 80 placental units. And you can separate them and type them in different types. But still the placenta is a very good model, the sheep placenta, to investigate human placental development. This has been shown in various different aspects, like vasculogenesis, like hormones and so on. And one very important hormone to look at if you think of there's an impact on fetal growth is placenta lactogen. And placenta lactogen is a hormone which is not only produced in sheep, you can find this in human as well. And this promotes fetal growth. And it's produced by those little cells, the binucleate cells. You can stain them, and this is a depth staining, and you see here this brown with 2 nuclei, and this brown indicates a cell with a lot of human placenta lactogen, and those cells migrate to the surface of the villi and then excrete this hormone, this placenta lactogen, in the maternal and fetal circulation, and that's how we think it regulates growth. And what we found when we looked at those placentas, that after betamethasone treatment, there was a decrease in numbers, there was a decrease in protein when you measure it, and there was a decrease in opioid protein levels in the blood. So betamethasone, glucocorticoid treatment, affects those cells. And this is, I think, a very nice explanation, possible explanation, why we see a decrease in fetal weight after glucocorticoid treatment. The question is, why do those cells decrease after antenatal glucocorticoid treatment? There are different hypotheses, like whether there's a difference in migration process, or there's probably something to do with apoptotic factors. And we investigated this, and very shortly only we did colocalization studies, and we also measured mRNA expression. We found increased placental apoptosis in those tissues. So this might be an explanation. We did a lot of other things in the sheep placenta, and I do not have the time to show you all those things, but there's a lot going on in the sheep placenta which might help to explain the differences and the change in fetal growth. So what's about human? In the retrospective case control study, we also found a decrease in placenta weight in the human cohort. But to do this prospectively, we started a single course antenatal betamethasone treatment protocol at the Charité, and we gave only 2 times 12 milligram glucocorticoid, and we were interested to see how this would affect growth and as well as placental development in a prospective study, and what we could show is that even a single course, 2 times 12 milligram, reduces birth weight compared to controls, reduced body length, and reduced head circumference.
Is the interval between metronidazole and when you check birth, how many days?
It was different. Like there was a huge range, but the interval did not correlate with the decrease in birth weight. Of course, you have to wait. Like if you treat and then the baby is delivered 2 days afterwards, you will never see any decrease in birth weight. But you adjust it for gestational age, so the control ones are matched with the betamethasone ones. That's a way how you can rule out the gestational age effect. And but with respect to placenta lactogen, which you find by humans as well, there was no change. So placenta lactogen does not explain the story in humans. Humans are not sheep, as we all know. But very recently, we were able to look at a different aspect of the human placenta, a hormone called 11-beta-HSD2, which basically protects in the normal situation the fetus from high endogenous maternal cortisol levels by inactivating cortisol to cortisone. And when we looked at those placentas who had received antenatal glucocorticoid treatments after stress, we were able to show actually a decrease in 11-beta-HSD protein levels and a decrease also in the activity when you measure the hormonal activity. But interestingly, only in females, when they were born after 37 weeks of gestation. Not in males. There were no differences regarding 11-beta-HSD2 in males. So to summarize, there is evidence from the literature about stress on the role of the placenta. In the sheep model, we found some very interesting things. I told you about the binucleate cells, the apoptosis. We also looked into glucocorticoid receptor isoform distribution and found some changes there. In human studies, there is the dose-dependent birth weight reduction. We could demonstrate this in ultrasound scans already. And even a single course can affect fetal growth. There were no changes in HBL there, but a decrease in 11-beta-HSD2. We also did some glucocorticoid transporters. So we would like to suggest that the placenta and the concept of prenatal stress exposure may play an important role in fetal programming and might explain some of those mechanisms which might be enrolled regarding probably transporters, regarding endocrine regulations of the placenta and regarding the morphology. And that the placenta has a placental adaptive response, so to the changing patterns, and that the placenta is not only a gatekeeper, as we all know, but is probably really a fortifier for programming effects. And this is, I would like to thank you for your attention, and I would like to finish my presentation.
So this was very nice. We did a lot of work, and we made it so easy for us to follow. Really. But any questions?
So, there will presumably be the benefits of antenatal glucocorticoids are demonstrated in certain populations, and there are clearly going to be some downside effects as well. So again, we're back to this balance, this trade-off. Can you, as we go forward into the future, do you think the indications for antenatal glucocorticoids are going to change?
Yes, so this is something like for the clinicians to take as a take-home message. So we have to make sure that the indication for ANS is a very strong indication, and this is how the protocols have actually changed, like not in our hospital, not only in our hospital, in other hospitals as well, and to use additional measures like cervical length, like biomarker measurements, to really make sure that only those patients get ANS who really benefit from, so that they deliver within the next 7 to 10 days after glucocorticoid treatment, and not as in the earlier days, repeatedly give it every week, or just give it because it's an IUGR fetus, and you think it's probably good.
But there is still a vogue in some centres to give it before elective caesarean section for mature babies.
Yes, but there are very good studies out, like the ANSEX study, where it could nicely demonstrate that the short-term benefit is probably there, but the long-term harm is not worth to treat those patients.
Sure. So I think.
And even the
how is this going to be disseminated throughout the entire obstetric world? Because you're right, the science is there, but the message hasn't gone through.
There's a huge debate between the United States, and they changed their guidelines very quickly after the Genf-Bannerman paper, and luckily they were now coming. They're going back now, and they probably will change it as well. But there's a big debate between the Americans and Europe, for example.
Well, again, I think...
But I don't want to blame antenatal glucocorticoid, not at all. So I think it's a very important, as I have tried to say at the beginning, it's very, very important. And it's very, very helpful in those babies who really need it, but not in those where we just treat it and...
What is your opinion on the use of betamethasone in cross-restricted fetuses, where there is not any evidence that it is of any work, any benefit?
Even there's our papers out which they show this actually harm, because you have a bigger centralization after.
And in the third world, they do harm.
So we don't know, and we don't know how it works in twins.
When we discussed with the neonatologist, they share the same opinion as we have. We would not use betamethasone in severely cross-restricted fetuses before delivering them. But since all the guidelines still underline the importance of, for medical legal reasons, we have to use this drug that damages these fetuses. So
the data in humans, though, with the IUGR fetus is not so strong. So there are some papers out who say it might harm, but it's not you cannot finally conclude from this.
but they're not
Okay, because there are two large randomized controlled trials investigating the use of repetitive glucocorticoids, and we have all long-term outcome data. And the Australian chairwoman of those trials, she wrote, the data clearly suggest or support the use of repetitive. And the Canadian chairwoman of the Canadian trials, because of those possible damages, you should refrain from doing so. And then, it's just the same data with a completely opposite conclusion. And then they came together with a single patient data meta-analysis, and then they said, well, you should consider repetitive, but the total dose should never exceed 48 milligrams.
But the dose, it's so interesting.
It's just what they say, and the data are all on the table, but people just want to prove their original hypothesis.
Yeah, but there was also exceptionally nice contribution we were both there on the perinatal meeting of Professor Schwab, who couldn't come today here. But, the question is the primary outcome of this American trial to use corticosteroids was the hours of CPAP. But I don't care whether my child has 1 hour more CPAP when it is more stupid at school 10 years after and less creative, because it attacks what you showed, the amygdala, it attacks creative capabilities for the whole life. And because it stops that myelization and migration. And you can talk to women. I talked in my hospital. I said, listen, this has been shown, these long-term effects. What does it matter when your child is a few hours longer at CPAP? Sorry.
And also the other aspect is like for us, the dose. I mean, nobody really has investigated whether 2 times 12 milligrams
Yes.
or 2 times 8 milligrams
But Schwab could
or 2
show
times
even
10 milligrams
low
actually
dose, you know?
if there's a difference. They only investigated the route of application, and that's what's also the Australian did. They injected it directly into the umbilical cord, and the effects on lung maturation were less, much less than the way doing with intramuscular. And this is also something where people think actually has to passage the placenta to have the same effects, but no data on dose.
No, but again, I come to these stupid political boards, what we have here, the Bundesausschuss, who makes it a quality criteria whether a pregnant woman gets corticosteroids. This leads to that all little hospitals, they just don't care what the cervical length. They give corticods as soon as the woman is entering the hospital, and that's harming more than doing any good. And this is because these politicians, until they understand that something might work, it is already, well, not any longer. Science is faster, you know. Yeah.
There is a trial at the moment in France comparing 12 versus 24.
No, 12.
Well, once 12 versus twice 12.
Right.
Not 24 in one shot. So it's still running, and it's going to be a long trial because.
Yeah, but I'm looking forward because this
Yeah.
will be the first
It's a real answer. It would be an answer to a real question.
Yeah.
When you look at long-term outcome.
Well, we're not going to get. I mean, the trial is still running. They're still recruiting, so we're not going to get long-term outcome before a long time.
Yeah.
But we're going to get short-term outcome already. And if there's no difference in short-term, I might as well use 1 to 12.
Yes.